Good morning, friends. This lecture is uh, about radiation oncology, a stepwise progress. In the first lecture, I will cover uh, how we switch over from two-dimensional radiotherapy planning to three-dimensional radiotherapy planning, and few basic uh, of radiation physics will be dealt in this chapter. So let us start by remembering the Sir William Conrad Roentgen, who was father of radiotherapy and a father of radiology as well. And he discovered the X-ray in 1895, and onwards the journey of radio diagnosis and radiotherapy begins. Regarding the radiation oncology portion, is involved the radiation therapy by use of ionizing radiation to kill the cancer cells as well as shrink the tumors as much as we can. Almost 60% cancer require radiotherapy treatment either alone or with a combination with a surgery or radiotherapy. And the radiotherapy is used by the most commonly external beam radiotherapy, either by the cobalt or a linear accelerator or a modern radiotherapy machines, and internal radiotherapy, that is implantation near or into the tumor or a lumen, that is basically called a brachytherapy. And the third form of a radiation therapy is a systemic radiotherapy, that is called radionuclide therapy, zetotherapy, also knows radioimmunotherapy, which is an emerging branch of a radiation oncology and a nuclear medicine both. So we know the radiation, how it kills the cells by killing the main part of a cell, that is in the nucleus DNA. Almost 75% of a killing happens by indirect action because the photons goes into the cells and the water molecules are hit, and then the waters is broken down in hydroxyl ion, and this hydroxyl ion is responsible for DNA damage. And furthermore, this hydroxyl ion combined with oxygen and form a peroxide, and then this damage is fixed. And then 25% of a killing by photon or X-rays is happen because of a direct action, like the photon directly damage the DNA, but this happens only in 25% cases. So both happens during the X-ray treatment of radiotherapy. A team of a healthcare provider helps to plan and a radiation treatment to deliver cancer patients, and a treatment planning and simulation are an integral part of a radiation treatment delivery system. The goal of planning is and simulation is to make the treatment more precise, more effective, more focused towards the tumor, and less damaging to the normal healthy tissues. So radiotherapy, as I mentioned, is also killing of cells by ionizing radiations by certain type of energies, different level of energies, and radiotherapy destroy the cells of an area being treated, and by damaging their genetic material, make it possible for cells to continue to grow and divide. Although the radiation damage both cancer cells and normal cells, but most of the normal cells usually recover because of a typical fractionation design of a radiotherapy delivery and giving a normal cells to repair their DNA and then reoccur from the radiation harmful effects. but that same does not occur with the tumor cells. By knowing the some part of radiobiology, that we must should be very very clear about this diagram, the cell cycle, that if you see analyze the tumor cells, we have in the tumor cells we have a cells not in the all the cells in the same phase. Few portion of the cells are G2M phase, the portion of the cells are in S phase, and a few portion of the cells in the G1 phase, that is a pre-synthesis gap, and G2 is a post-synthesis gap. So we know that the cells, those who are in a G2M phase, are most radiosensitive, and the cells, those who are in tumor cells, those who are in S phase, are most radio resistant, because as much as radiation damages, the synthesis occurs, so that it has been compensated. So if we give a first fraction of a radiation, the only G2M phase cells are killed, but the cell cycle is continue progress, and then cells from the S phase move over on the G2M phase, and then again in the next fraction, this G2M phase cells killed. So that's why that process goes on by the multiple fractionation regime, and this happens. This is a basic radio biology in the treatment of cancer by radiation. So type of external radiation we used here is a photon, X-ray, electron, and now we are added with a proton. With the Apollo Protons Cancer Center was the first at Chennai who launched this proton therapy. Is typically used in the brain tumors and the certain tumors where BRAC-P utility can be best utilized with the proton therapy. There are different type of radiation and different ways to deliver the radiation. For example, certain type of radiation can penetrate more deeply into the body than others. In addition, some type of radiation can be finally control and treat only small area without damaging the nearby tissues. Other type of radiations are better for treating the larger area. So a different radiation, and a surface tumors can be better treated with electron treatment. So you see here in the basically when the electron beam hits the target, and I mean this way of generating the X-rays. So the few of beams or X-rays, you can say beamlets, they are of lower energy or more scattered, like 400 kV, and then 4 MV, and then you go to see here in the diagram 20 MV. So as much as the energy is high, because after this hitting of electron beam on the target, the spectrum of energy is released. So we do not want that spectrum which are not useful. So we want deep penetrating. If we want deep penetrating, like a 20 MV here is shown, is having a more forward direction and a more focused rather than the weak intensity radiation, which are more scattering and not used unnecessarily producing the radiation reaction. So typically we should know about the X-ray mode of a linear accelerator and electron mode of X-ray electron mode of a linear accelerator head. We see here the target X-ray primary collimation, and we know the spectrum of energy is released, so we required a beam flattening at the certain point and a depth. So we required a beam flattening filters, then an ion chamber for dosimetry, and then a built wedge. And multi-leaf collimator is the integral part which is being discovered with a linear accelerator with a lot of for a conformal therapy, and X and Y independent jaw, and that is called secondary collimator. On the contrary, on this side of image we see the window, the primary scattering foil for electron beam, and then secondary foil, primary foil, and between the secondary foil, the primary collimators are applied, the ion chamber, the light and mirror, again the secondary collimator. But you see here is a difference. There is electron cone applicator because electron beam is spread very fast and then is useful for treating the superficial tumor. So, because of a rapid fall of dose after the Dmax, so for stopping the scattering of electron, we put from the head to up to the patient surface where the beam is directed to treat the superficial tumor, which is used here. The beam flattening filter is not there in the electron mode of a head because we have usually you get a uniform beam in the electron for the electron purpose. So how does the doctor measure the dose of radiation? The amount of radiation absorbed by the tissue is called radiation absorbed dose and was described well before 1985, and that is rad. Now this rad is being called as a gray, and the gray 1 gray is equal to 100 rads. That means the 1 centigrade is equal to 1 centigrade is equal to the same as 1 rad. The different tissue can tolerate various amount of radiation measured in many ways. For example, a liver can receive total dose of 30 gray, that is 3000 centigrade, while minimum damage to the healthy tissue. So every organ have a tissue tolerance dose, that is TD 5/5 and TD 50/5, and then also depend upon the volume of tissue tolerance depend upon the volume of the tissue you have taken for a radiation planning. Like in the lung, one resident must remember about the all the tissue for tissue tolerance dose, so that while planning on the computer you can see that that amount of a dose, certain amount of dose should not exceed to that critical organ beyond the TD 5/5. Otherwise there will be serious side effects. So that is I want to convey you guys. Then Holston's curve, that is therapeutic ratio that you see here is the tumor control and tissue damage. Both the curves as much as possible is there. The gap as much as possible, because we want to kill the tumor cell as much as possible and normal tissue to spare as much as possible. So doctors work with this figure, therapeutic ratio. The ratio comprises damage to the cancer cells, tumor cells in compared to the damage to the healthy cells. Techniques are available to increase the damage to the cancer cells without doing a greater harm to the healthy tissues. The X-rays or gamma rays both form of electromagnetic radiation, though they are produced in a different way. Both use photon. X-ray are created by machine, like generated by machine, the right term, and then by linear accelerator, hitting the electron on the target produce X-ray, and without directly electron can be used for the superficial tumor. And then X-rays can be used for a lower energy for a superficial and a higher energy for a deep-seated tumors. Gamma rays are produced when the isotopes of certain elements such as iridium, cobalt-60 release radiation energy as they break down. Each elements break down at a specific rate, and each gives off a different amount of energy which affects how deeply it can penetrate into the body. We know the gamma rays is produced by the breakdown of a cobalt-60 used in the treatment. External beam radiotherapy heavily in the cobalt, and then for gamma knife is for a brain tumor, AV malformation, acoustic neuroma, single solitary brain metastasis. The gamma knife use array of 207 cobalt sources arranged in the heavy shield head frame used for the gamma knife. There is also called subatomic particles like electron, photon, proton, neutron, alpha particles. These are called particulate radiations. The particles like linear accelerator generate electrons as well, and cyclotrons to generate the proton. So as of now, we have electron treatment and a proton treatment. So though the work has been done on the neutron and alpha particle as well, but for the clinical use, the electron therapy is much of use in globally, and then as well as now added with the proton treatment. So now, keeping these things in the mind, now I'll take you to the external beam radiotherapy treatment process, and purely the 2D radiotherapy planning. What is 2D radiotherapy planning? When that only two dimension is covered. First dimension is height and second dimension is the width. So there is only two. But what about the third dimension, that is the depth of the tumor, which is not being covered in the typical 2D radiotherapy planning. And the bony landmarks are crudely used here. And then X-ray fluoroscopy, why we see the bony landmarks, and they design the field in the square. So the tumor, considering the fact the tumor is not in a square and a rectangular, tumor is highly irregular. So you can say that we can use we used to use by the help of styrofoam cutters, the blocks is made customized blocks to protect the radiation, but was not a very useful. And then the dose calculation was again a problem. So it is 2D dimensional planning is more precisely nowadays more commonly used for a palliative care. Generally, if you take get a CT scan of a patient on a single slice you take for a radiotherapy planning purpose, it is basically a 2D planning. The central plane through the target will generally taken as the area of entire volume. So we use the two-dimensional radiotherapy planning quite heavily in the palliative setup as well as in a carcinoma cervix, in a cobalt-based radiotherapy system. Four-field box technique is quite effectively used. But what was the limitation of radiotherapy? In 2D planning, the radiation treatment has been done in only two dimensions. Width and height is considered. But what was about the depth of a tumor was not considered. A lack of involvement of defining the clinical problem, deficiency in a logarithm for computing the dose was the biggest problem. And a failure to compute the dose throughout the volume of interest was again a big problem. And certainly we cannot afford to have handle the treatment for a non-coplanar beams in the 2D radiotherapy planning. Failure to provide the estimate of error, inadequate definition of geometric coverage of anatomical structure by external beams, a failure of providing tools for specifying and verifying the accuracy of treatment delivery was the problem. So there was a certain problems and limitations in the 2D planning that further propels the persons to look for the three-dimensional radiotherapy planning, the three-dimensional conformal radiotherapy planning. This is forward planning and allow the doctor to more precisely target a radiation beam, including the width, height, and a depth. Because of a CT scan, you can get a depth as well. By many radiation oncologists use this technique. It has been proved that the CT-based planning improved for all cancer 5-year overall survival by 3.5% and was particularly more useful when the tumor volume is very less. Small size tumor volume. The steps we do for getting a CT scan, CT simulation done, and then after CT simulation, the slices is by the ECOM methods. Server is being transferred to the treatment planning system, and where we control slice by slice tumor. Suppose the 5 slices are there having a tumor, and the cuts are there of 1 centimeter. That's a tumor size is 5 centimeters. If you add margin of a 1 centimeter on up and down, and this thing, so that you can kind of cover the 7 millimeter field. So that's actually we first do the contouring. After the contouring, designing the beam, field shaping with the help of beam side view, and after the beam side view, do calculation, and also side by side we contour the critical organs in the falling in that area, so that we can see the dose received by the critical organs. Treatment documentation and plan and treatment verification was an added advantage in 3D radiotherapy planning. The 3D relies on the basically on the 3D's computed tomography. The beams can be much better delineated with respect of soft tissue boundaries here, where we have based on only bony landmarks, and a modern radio accelerators with the multi-leaf collimators produce irregular field shape without having a with a pain and difficulty designing the blocks in a 2D planning. Here we can easily create a irregular field by the help of multi-leaf collimator without using a block and etc. Treatment verification in 3D conformal radiotherapy still is a problem. So you see here in this diagram, typically CT scan image, we acquire the CT simulation, contouring slice by slice all the tumors serially ups and down by picking up the central slice and including the margin. Then you can collect a volume of data, and a volume of data, then you put a DRR. When we combine all the CT slices images and get DRR image on the, it's all by the help of 3D treatment planning system, very costly system. And typically we ask 5 millimeter slice for thickness in the head and neck cancer and 10 millimeter slice for the chest, trunk and pelvic tumors. So use typical isodose distribution on 3D TPS for 3D conformal radiotherapy planning. You can see on the TPS that's critical organ dose received there, and nearby tissues how much dose is received, and whether the tumor is covered the 90% dose. We can see with this 3D treatment planning system. And then some you see here, then the linear accelerator, the EPID is there. Sometimes the image verification just before the treatment is very much required. So the same linear accelerator, low energy beams can be utilized for taking the images, the flat panel matrix, and then you can see the image, and then recorrection can be performed. So electronic portal imaging devices sometimes is also, you can not only verify the image, you can go for a dose given to the area of interest can be calculated by electronic portal imaging devices. It can store a dose. So you see here the multi-leaf collimator system irregularly open, so that irregular shape of a tumor is being covered in the 3D CRT. But what about the tumor is not only irregular, sometimes tumor is somewhere thick, somewhere thin, and we required a dose inhomogeneity in this area, and that is the area we think of intensity modulated radiotherapy in this modern area. Because tumor may be concave, so that unnecessary radiation, or a thin somewhere, and behind that there is a critical organ, so you have to restrict the dose to that area. And then so we create a dose matrix, basically dose painting, on the flat panel how much dose is received for this particular point, so that the limitation is of 3D CRT was compensated by IMRT. So you see beautiful images of the multi-leaf collimators. Radiation is delivered by the linear accelerator with equipped with multi-leaf collimator. Shape or sculpt the beam's radiation. Equipment can be rotated around the patient so the radiation beam can send from the best angles. Beams conform as closely as possible to shape the tumor because IMRT is not used in every type of every kind of a tumor treatment. So we also follow the formula of ICU guidelines given in the 50, 62, 83, the latest of 2010. We defined the gross tumor volume, we defined the clinical tumor volume, then we defined the setup margin, internal margin, and finally the planning tumor volume which we treat. The limitation of 3D CRT discovered in the limitation of 3D CRT. The 3D CRT actually was discovered by Takahashi in 1960 and has a significant advantage over 2D planning. The 3D CRT beam have a uniform radiation intensity across the entire field, thus can conform the radiation for concave structures such as tumor, those who have. But the limitations I'm telling about the tumor, those who are somewhere thick, somewhere thin, and a concave in structures. So 3D CRT was not handy in that, so that lead to the discovery of IMRT. The close working relationship between the radiation oncologist, radiodiagnosis fellow, pathologist, physicist, and surgical oncologist is very much needed here. And it has been seen a term used, doctor delineation error. It has been coined. We see that if a same tumor is contoured by the radiation oncologist and the same tumor is contoured by the help of radiodiagnosis, there are some minor differences is there. So it is better to join hand with a radiodiagnosis fellow to better delineate the tumor. Because there are so many types of radiation, treatment planning is very important step. First, every patient who have radiation therapy before radiotherapy is given, team of radiotherapy determines the amount and the type of radiation the patient will receive. The patient having external radiation, the radiation oncology use process called simulation to define whether it aim is radiation. During the simulation, patient lies still on the examination table while radiation therapists use a special X-ray machine to define the treatment part of field and exact place of the body where the radiation will be aimed. That is being checked on by the help of laser beams, so that rotation is not there in that being taken care during the simulation process. So there are immobilizing devices which we used here, like a immobilization device for head and neck cancer, for trunk, for brain tumors. You see here in this image the alpha cradle polystyrene beds to immobilize the patient, young patient who are, they're not very, compliance rate are low. We can use this, and furthermore, by using these alpha cradle, you do not require to mark the patient body. You can mark on this alpha cradle, and that's a marking. Same thing happened for head and neck cancer using a mask. You can mark on the mask. A patient remove the mask and then go back to the home, rather than putting the marks on the skin that the patient's the cultural taboo and stigma is there. So what is the difference between the normal CT and a CT simulator? The major difference is one, the typical wide bore's aperture is there in the CT simulator. Almost CT scan normal is having a 70 centimeter diameter, but almost the CT simulator having a 80 to 85 centimeter wide bore. Why we use wide bore here in the CT simulator? Because we have to accommodate the immobilization devices. Sometimes, like you have planned for the breast cancer, want to go for the CT simulation after the marking and then everything done. So you require a wide bore so that these large size immobilization devices can be accommodated. And now the oncology stepwise radiation progress that in my second and next subsequent lecture would be conversion from 3D to 4D part 2, which will transmit very soon. Thank you very much.